I'm still Ahmed Shatila. There we go. So as you know, name hasn't changed, credentials haven't changed, and my disclosures haven't changed. Today's lecture, I'm going to be talking about dementia for primary care. Save time, stop melting down. This webinar is sponsored by Lundbeck Pharmaceutical. As you can see in the back, you have pictures of melting memories. And with that, here are my disclosures, still unchanged. I'm going to present to you a typical memory loss patient that I see at SSMC hospital. This is a 75-year-old male with a past medical history of diabetes and hypertension and is brought in by family for memory loss over the past 4 months. According to the family, he wanders around the house, he talks to dead relatives, and he gets extremely irritable and agitated. And when you ask the family, when did this happen? They're like, oh, 4 months ago. He was completely normal before that, they tell you. Now on examination, the patient is alert. He's only oriented to person, not the place, not the time. His speech is incoherent. Cranial nerves are unremarkable. He can walk, but he's in a wheelchair. But what's significant is that you notice he's wearing a diaper. So I want you to keep that in mind as I go through this presentation, why this patient is wearing a diaper. Mild cognitive impairment. And mild cognitive impairment, or MCI for short, the changes in cognition exceeds the normal expected change relative to age. This is not about I forgot my keys or I forgot what's for dinner. This is something bigger than just normal things that we forget on a day-to-day activity. Symptoms of MCI are often vague and include memory loss, language disturbance, difficulty in finding words, attention deficits, deterioration in visuospatial skills. Can we press? Oh, there we go. Visuospatial skills. The treatment of MCI, there are no treatments for MCI. What we try to do is we try to tell patients exercise regularly, control the cardiovascular risk factors, participate in mentally stimulating and socially engaging activities. And experts recommend that persons diagnosed with MCI should be reevaluated every 6 months to determine if the symptoms are the same or if there's any progression. Now, what is dementia? Dementia is a progressive neurodegenerative disorder. It's characterized by cognitive and behavioral changes. Eventually, people with dementia will not be able to live independently, thus increasing the burden of care for their family, their require nursing care, and overall burden to society. What are the symptoms of Alzheimer's disease, which is the most common cause of dementia? The cognitive symptoms include memory loss, impaired temporal orientation, impaired praxis or the ability to learn procedures such as brushing your teeth, combing your hair, cutting your nails. There may be language or executive disturbance. There's also functional systems include reduced ability to carry out activities of daily living, dressing, handling money, personal hygiene. There may be behavioral or psychological symptoms as well, such as mood swings, agitation, aggression, and one. Water's good. Memory. Memory is broken down into working memory, short-term memory, and long-term memory. Working memory is the memory, procedural and working memory, such as, when you're usually, you see a number, you want to call someone, you see his number quickly, you memorize it for like 5 seconds, you dial it, then you forget about it. That's your working memory. Short-term memory are what we learn that lasts a little bit longer than, a couple minutes. And long-term memory are a sense of self, where you were born, who you are, who your children are, who your parents are. This is usually the hardest memories to lose. But eventually, even with Alzheimer, the long-term memories will get affected. What are the cognitive deficits in Alzheimer's disease? Like I said, you have memory impairment, difficulty in learning new information, or forgetting previously learned behaviors. You have aphasias, impaired language function. You have apraxias, like I told you, it's the inability to perform previously learned skills and the absence of any motor weakness. So this is a person who can't brush his teeth, not because his hands are weak, but because he just doesn't know how to brush his teeth. Agnosias, failure to recognize objects. eventually progressing to not even recognizing family members or their own reflection. You have a decline in executive function, and you have spatial temporal orientation may be affected. How do you diagnose it? It's clinical and radiological. Now, what you should see is you should see a progressive decline in memory on both clinical exam as well as neuropsychological tests. And if you have, and then you have criteria, you have definite dementia, that's when you have the clinical diagnosis with histologic confirmation, either brain biopsy or autopsy. But let's be honest, we are not doing biopsies on dementia, and autopsy is only after the fact. We may look at it and say, oh, he has it. So most of us are not diagnosing definite Alzheimer's disease. Most of us are diagnosing probable or possible Alzheimer's disease. What's happening in Alzheimer's disease or dementia? On the left, you can see a normal cross-section of the brain. You can notice the temporal lobes are full. The hippocampus is normal size. The ventricles are small. And the sulci and gyri are nice and full. There's no atrophy. Look on the right. Now, when you notice a person with dementia, the ventricles are enlarged. The temporal lobes are atrophied and small. The hippocampus is smaller. And the gyri are now smaller. The sulci are deeper. That's a typical brain of someone who suffers from dementia. On PET scan looks at, the functional aspect of the brain. On the left, you have a PET scan of a normal brain of someone who's taking radioactive glucose. And what you're seeing on the left, normal uptake of radioactive glucose, FDG glucose. And you can see red, there's normal metabolism throughout the brain. On someone who suffers from Alzheimer's disease, everything is hypo. It's all blue, except for the deep gray matter structures, as well as the mesial-occipital lobe, which is intact. But overall, you have a global hypometabolism of the brain. How do you treat Alzheimer's disease? Treatment is basically broken down to two classes of medications. You have the cholinesterase inhibitors. These drugs work by boosting the level of acetylcholine in the synaptic cleft, thus helping people improve their memory. Now, because it's an acetylcholine esterase inhibitor, you do get symptoms of diarrhea, nausea, loss of appetite. You have to be careful about people who have any cardiac abnormalities because it can cause arrhythmias. And then you have another class of medications called Mementin or Namenda. It's an NMDA agonist. And what that does is it binds to the NMDA receptor, which is also a receptor that glutamate binds to, thus improving the functionality and memory of someone who suffers from Alzheimer's disease. And I'll be talking about that a little bit later. So what's the concept of clinical progression? So as you can see, one of the ways that you can look for dementia, or at least assess someone in clinic, is by doing the MiniMental Status exam. 30 is you have a normal exam. 0 means you're dead. And as you can see, in early diagnosis, patients may have just mild symptoms and their MMSE is already fluctuating between 25 to 30. Once you diagnose them, their MMSE is down to 20. So they've already dropped down 10 points. And by the time they get to a nursing home, their MiniMental Status is now 5. So what is the MiniMental Status? It's basically a questionnaire that you can ask. You can download this off Google. What you do is you ask patients age, date of birth, location, season, month, year. You can do serial 7s. You can ask them to spell world forwards, backwards, remember 3 items, read something for you, write something for you, intersecting pentagons. And it's a very good way to at least see if someone has a baseline deficit in memory, but also you can look for progression. Now, the only thing about the MiniMental Status that I will tell you to keep, kind of be aware about, some patients, especially in the UA, what I've noticed is a lot of my patients don't know the date of the year. Especially my elderly patients, when you ask them what's the date, they're like, I don't know. The year, they're not really sure. But, I think it's just more cultural, but also at the same time, they may not know, they may have never went to school. So you got to kind of hold this exam with a grain of salt, as they say. And I had one time a patient who did horribly on the MiniMental Status, but one thing he did was he told me what camel won the race last week. And I don't follow camel racing, so I look at his son and he's like, yeah, that's right. And then he told me what camel's going to race next week. So, you know, at that point I looked at him and said, you probably don't have Alzheimer's dementia, you're doing really well. But even though you look at his MiniMental status, it was horrible. So you got to look at it, you got to sometimes use it with a grain of salt, especially with some of our older patients. So glutamate, what's happening with glutamate in the brain? As you can see in this illustration, you have the presynaptic cleft, you have the presynaptic neuron, the postsynaptic neuron, and you have the synaptic cleft. And in this, what's happening is there's a release of glutamate. Glutamate binds to the NMDA receptor, thus causing depolarization and thus causing normal axonal function. It's an excitatory neurotransmitter. Now, the glutamate gets taken up by the astroglial cells, gives off an ATP, then goes back into the presynaptic where it's recycled again, and the process repeats over and over. Now, in Alzheimer's disease, you have an impairment in glutamate release. You have an impairment of glutamate function. It cannot be imported into the vesicles, and that this whole system, as a result, is now impaired, thus affecting memory. That's the way I usually understand it. Glutamate 101. For neurologists who are not biochemists. Now, what does Mementin do? It binds to the NMDA receptor, thus increasing the amount, or acting as if there was a normal amount of glutamate in the system. And what this does is it restores synaptic plasticity, learning. It reduces tau phosphorylation. And Anabixa has been shown to cause improvement in synaptic plasticity and learning. It's been shown to have a neuroprotective effect when used to treat Alzheimer's disease and slow down disease progression. What's the effect of Abixa on cognition in patients with moderate dementia? As you can see in this trial, basically patients who receive placebo versus Abixa Namenda, Mementin, is that there's an improvement in language, an improvement in memory, an improvement in orientation, improvement in praxis, as well as visuospatial. This is all significant compared to placebo. When you look at communication, significant improvement for patients in their communication skills in the ones who received Mementin versus the one who received placebo. And if you notice, the curves start diverging really early, and by 4 weeks, they were already statistically significant. And this is what I see in clinic. Usually by the second week of taking Mementin, patients' families are usually telling, yeah, there's usually a difference. They usually will tell you, I noticed something different. Grandfather or my father is just a little bit better.
5 minutes, Dr. Shatila.
Okay. What are the benefits and activities of daily living? Improvement in ability on all activities of daily living, whether it's standing, dressing, eating, drinking, or using the toilet, all compared to placebo. What is the effect of Namenda, Mementin on, I say Namenda, Abixa or Mementin, Namenda's in the States. There was a benefit observed in the symptoms of delusions of agitation and aggression. Mainly there was decreased aggression, decreased irritability, decreased and improved appetite. So, and overall, what did this equate for? It equated for 51.5 less hours of caregiver time per month. That means more time for family members to do other things, less time to be observed, and less time to watch the patients. Overall side effects, placebo-level side effects. There was no significant difference in people who received Mementin versus people who were on placebo. Overall summary. Disease progression in Alzheimer's needs to be measured by a composite clinical assessment. In clinical trials, Abixa had consistently shown improvements over placebo in cognition, function, and behavior. However, in degenerative conditions like Alzheimer's disease, stabilization is very important. Abixa has been shown to produce clinically relative outcomes by reducing the rate of clinical progression, helping to prevent the emergence of key symptoms, augmentation of the cholinesterase effect in clinical course in Alzheimer's, and extending time to nursing home administration. So, when you go back to this patient, why is it that this patient presents to my clinic wearing a diaper? And you know, I always say, and one thing I used to notice in the US, when I used to see patients with Alzheimer's, they used to come to me right early, right? Usually right when they're starting to forget things. In the UAE, I tend to see patients that are coming in older, wearing diapers, more disabled. And the question is, why is that? And for a long time, that used to perplex my mind. Why is it that we're seeing patients older in diapers? Is it that the parents, the family doesn't care? But you look at the family, they do care. They come to every appointment, they take care of their loved ones. And I think one of the reasons why we see people later on is due to cultural. I mean, if you think about in Eastern cultures, what do we do? The first thing when you graduate, when you get a job, you help out mom and dad. You tell dad, you don't have to go do the shopping or pay the bills. I got it. You tell your mom, don't do the cooking. I'll take care of it. You tell your mom, we'll take care of all the cleaning. So what happens? They stay at home. They don't do anything. Their ability to do things, their daily routine changes, and as a result, you don't notice the mild deficiencies. People equate, oh, they forget a name, they just brush it off. And when do they really notice it? It's when they lose the major life activities of daily living, urinary incontinence. And that's when they bring it to me and they say, Dad is wearing a diaper. This happened 4 months ago, when in reality, it probably happened 4 years ago or 5 years ago. So in summary, stay active, keep your family members, keep your patients active. Make sure they come to clinic for follow-up. I know in a lot of time patients they'll come for follow-ups and they'll send their driver, their nanny, they may send other family members. No, insist that the patient comes so that you can talk to him, see how he's doing, make sure there's no progression of his symptoms, because if you don't see them, you don't know if they're progressing. With that, I will end my presentation. Thank you very much. And I think is there an MMSE for Arabic patients? That's a good question. I've never looked into it because I usually use the English one. I'm sure there is one. There are definitely, you may have to look into it, or you may have to actually get it translated. It is an easily translated exam, but I use the English version, so I've never really asked about the Arabic version of the MMSE. With that, I would like to
one question. One question came in at the start. Said, does dementia occur in young age group under 50, and is aphasia part of it?
So dementia can occur in young age group patients, but usually if someone has young age dementia, you got to start thinking about the hereditary forms of dementia. Can you have aphasias? Yes, you can, but it's not usually with Alzheimer's disease. Aphasia is usually the last thing to go. It's not the first thing. If you are seeing dementia with language deficits early on, you have to think about one of the more other causes of dementia, such as frontotemporal dementia or Pick's disease. That usually is more heavily frontal lobe dominant, language dominant. And Alzheimer's disease is more posterior, visual spatial, parietal lobe, and language is not the first thing to go.